This is First Pediatrics. Hey everyone, my name's Chris, and welcome back to First Pediatrics. I'm fortunate to be joined by Emily, who's one of our current chief residents who's going to be taking the lead on this case today. Emily, would you mind introducing yourself?
For sure. Thanks for the nice introduction, Chris. So my name's Emily. I am one of the current chief residents, and I will be starting my cardiology fellowship in July. Outside of medicine, I enjoy walking my rescue dog and rock climbing, which is a hobby that Chris and I have in common.
Congratulations on your next steps, Emily, in cardiology as well. So, Emily, would you mind telling our listeners about our podcast?
Sure thing. First Pediatrics is a peer-to-peer podcast geared towards pediatric resident education. Our goal is to address your first management experiences by bringing you evidence-based content to help you on the wards and make daily life more manageable as a resident.
Thanks, Emily. Can you also walk us through the topic for today and why you think it's important for our learners to know more about?
I'd love to, Chris. Today we're going to be discussing a topic you'll see frequently throughout your medical training, elevated bilirubin level or hyperbilirubinemia. This is a problem that can range from being totally normal to life-threatening, and we see it in all areas of pediatric care, both inpatient and outpatient. Being able to quickly differentiate between normal or physiologic versus abnormal bilirubin levels and coming up with a management plan will be an important skill to learn as a pediatrician. Over the course of today's podcast, we're going to build a schema for organizing causes of hyperbilirubinemia, review the pathophysiology of bilirubin production, conjugation, and excretion, and recognize labs and exam findings that give you a direction for how to approach this problem.
That sounds great. So do you want to start with the case?
Let's do it. So this is a patient that I encountered within the last few years. It was the height of the COVID-19 pandemic, and I was called in to see a 2-week-old newborn.
Okay. So what brought this family into the emergency department today?
Yeah, when I asked the family, they said they brought her in because her eyes looked dark and her belly looked bigger.
Can you tell me any more about the patient's history?
Yeah, so the family noticed that her eyes were becoming darker, a more yellow color actually, and that her belly was looking bigger. It was more gassy or distended is how they described it to me, and it had been worsening over the past few days. She's otherwise been feeding well and having normal stools per the family. They described it as a very light brown color. Otherwise, no noticeable skin changes, fever, diarrhea, or vomiting. She had a little bit of a runny nose, but that's been going on for the past few weeks.
Okay. How about past medical history, any birth history that's notable?
Yeah, so she was born at 37 weeks. The pregnancy was notable for maternal hepatitis C. The mom had an undetectable viral load, and mom was also GBS positive but was adequately treated during the delivery. The baby lives with her siblings and parents and has not had any recent travel. She is formula fed, and per the family, she is growing and developing normally. So that's the highlights of her history. Now let's jump into the physical exam. Is there anything specific that you'd like to focus on?
So since I'm worried about hyperbilirubinemia, I would like to get a good skin exam and belly exam, thinking about liver pathology and enlarged liver. I also like to make sure that I get a good general exam. So what is their general appearance and her mental status too?
Yeah, so when I walk in the room, she appears alert, is responding appropriately to my exam. She has a bit of a protuberant or larger belly. She has a darker skin tone, which can make it a bit harder to appreciate the degree of yellowing of her skin. But when I looked in her eyes and her mouth, her eyes were very yellow, and her hard palate was also jaundiced. I, like you said, wanted to do a really good liver exam on this baby. And so I started by walking my fingers up from her pelvis and then all the way up until I felt her liver. And I felt it around 2 to 3 fingers below the rib line for her. So before we jump into her specific lab values, let's take a step back and review the mechanism of bilirubin production, conjugation, and excretion. Chris, what is bilirubin? Going way back to the beginning, what is it? Where does it come from? And what's the difference between indirect and direct bilirubin?
Well, good thing I did my homework. So bilirubin is a natural breakdown product of red blood cells. Hemoglobin, which is the oxygen-carrying molecule that we all know within red blood cells, is broken down actually by macrophages into heme and globin. That heme molecule is processed then into indirect or unconjugated bilirubin. Isn't it lovely in medicine how we have multiple names that mean the same thing? So indirect and unconjugated bilirubin are the same thing. Since it's unconjugated, it's not water soluble, and it's actually carried throughout the body by albumin. The liver then uses enzymes to conjugate it. So indirect bilirubin that has been processed by the liver is then called conjugated bilirubin or direct bilirubin.
Awesome. That's right. And the name of the enzyme within the liver that conjugates bilirubin is called uridine diphosphoglucuronic glucuronosyltransferase. I totally nailed that one.
Wow.
Otherwise known as UDPGT, and it does exactly what you just mentioned. Once bilirubin is conjugated, it enters the bile ducts before going to the GI tract to be excreted, which happens mostly in the stool, but also a small amount in the urine. And remembering a little bit about the pathophysiology of bilirubin can help you generate a differential diagnosis. So, Chris, what is one of the most feared complications of hyperbilirubinemia? And does this apply to both the indirect and direct forms?
So the most feared complication you're likely thinking of is bilirubin encephalopathy, commonly called kernicterus, right?
Mm-hmm.
The other thing I want to mention is that indirect bilirubin can cross the blood-brain barrier, while direct bilirubin cannot. So only indirect hyperbilirubinemia situations can you get neuronal damage, such as kernicterus.
Bingo. Now, what if I told you that this patient's indirect bilirubin was 14 out of a total of 17.8? And remember that direct bilirubin plus indirect bilirubin equals the total bilirubin. What would you have on your differential for this patient?
Yeah, so just like big buckets to start off with first, I think about first increased bilirubin production and impaired conjugation. So what I mean by this is increased breakdown or consumption of red blood cells. And then the other cause could be that the liver is just not conjugating or working well. That would be causing unconjugated hyperbilirubinemia.
Yeah, I think this might be a good time to bring up the most likely cause of elevated bilirubin in newborns. Can you recall the mechanism of physiologic jaundice, and is it direct or indirect?
Sure. So physiologic jaundice is a form of indirect or that unconjugated hyperbilirubinemia. It's most frequently seen in infants due to their high bilirubin production, such as the short half-life of their red blood cells. So they have more breakdown because they have fetal hemoglobin as they're transitioning to making more adult-type hemoglobin. They also have an immature liver, so they're not actually conjugating bilirubin well either. One other thing to mention is that there's greater enterohepatic circulation in newborns, which means that bilirubin is absorbed in the GI tract and recirculated throughout the body, which can increase the total body bilirubin, notably in the first 2 to 3 weeks of life.
Yeah, you nailed it. I think a few other pearls about physiologic jaundice is that it occurs after the first day of life and can last up to 1 week, with peaks around days 3 to 5 for a term infant. This is prime pediatrics boards material. Also, studies estimate that an infant has only around 1% of their functioning UDPGT or conjugation enzyme compared to an adult. So just some interesting facts there. Chris, time to tap into your physics background. Do you know why we place children under blue lights with an indirect hyperbilirubinemia?
I think that's a great question. So light, specifically blue light, converts the indirect bilirubin into a water-soluble form of bilirubin, so it can be excreted in the urine. So since I'm a physics guy, right, that light is a wavelength of 460 to 490 nanometers, which is blue light. A common misconception is that this is UV light. It's not a tanning bed. And it's oftentimes nice to bring this up with the families so that they know that we're using visible light that's very safe.
Exactly. Love a good physics throwback. Though we would not likely need to use phototherapy or blue lights for every physiologic jaundice case, what are some reasons we might have a pathologic or too elevated indirect bilirubin level?
Nice. So the most likely cause would be dehydration, actually. So something like reduced intake jaundice or breastfeeding jaundice.
Hmm.
And this happens because of reduced intake. Babies actually poop and pee less, which means that they're unable to get rid of the bilirubin in their system, which is the main way to get rid of it. And then their liver is not able to conjugate bilirubin well. Other causes of increase in bilirubin, the indirect form, would be red cell turnover. So thinking about hemolysis, trauma, bleeding. So for hemolysis, I think about, destruction by antibodies. So ABO incompatibility, Rho incompatibility with mom, if they had a transfusion. You could also have red blood cell structure defects, such as spherocytosis, or enzyme defects like G6PD. Additionally, you could have more cells, such as in polycythemia, which could also be a contributor. And then thinking about that trauma bleeding part, if they had instrumentation for delivery, like forceps or vacuum delivery, they could develop a cephalohematoma or a bruise essentially under the skin. And when your body breaks down that bruise, you could have elevated bilirubin as well.
Perfect. I think it's helpful to hear about, reduced intake jaundice instead of breastfeeding jaundice. I know as an intern, I would just be like, oh, if they're formula fed, this can't happen. So that's
Mm,
helpful to know that it's more of a reduced intake jaundice.
hmm
And so, since bilirubin is formed by the breakdown of red blood cells, you should always think about some type of abnormality with red blood cells for indirect hyperbilirubinemia. You also mentioned impaired bilirubin conjugation. Do you remember some examples of this?
Yeah, sure. When I was talking about the big buckets, right? The impaired
Right.
conjugation piece. So, some exam type things and throwbacks might be things like Gilbert or Krigler-Najjar, which is like they have that partial or full enzymatic failure to conjugate bilirubin. Other reasons why you might be conjugating things well is because of over liver failure or troubles with your liver, whether
Hmm.
you have hepatitis, an infection, heart failure that causes hepatic congestion, or even like clotting within the liver itself.
Hmm.
So really anything that might make the liver fail to perform its job would be an issue. Now, this can also be things like sepsis. So if the baby's very sick, or let's say they're very premature, we've already said that full-term infants have 1% of the functioning liver as an adult. So when you're premature, it even affects it further. So that oftentimes can contribute to the conjugation piece. You oftentimes hear things like breast milk jaundice, which sounds like a lot of the other things we've talked about, but is different. So there's thought to be some interplay sometimes between the breast milk and the conjugating enzymes within the liver that we've been talking about that can impair conjugation. And this sometimes happens closer to day 6 going forward and can persist for 1 to 3 months.
Got it. And so I know, Chris, you have this memorized in the back of your mind, like all of these different causes. But I think it
hmm
is worth saying you can always look up these specific differentials. And it's extremely helpful to understand the mechanism and the general buckets, but you do not have to be as smart as Chris and have everything, memorized and right at the tip of your tongue when your attending asks you.
Sometimes being smart is just being prepared, and I prepared.
Right. Yes. Knowing your resources. So jumping back to this case, what if I told you that this patient's direct bilirubin was 14 out of a total of 17.8 and that she was actually 6 months old? So this was actually the case that I walked into. So sorry for lying a little bit earlier. So now you have an elevated direct bilirubin and the patient is older at 6 months. How would this change your differential?
Yeah. So this is troubling, right?
Hmm.
An elevated direct or conjugated bilirubin is never something that should be ignored. Yeah, so I'm worried.
Hmm. How would this change your framework for thinking about this elevated direct bilirubin?
So now that we're thinking about a direct bilirubin, a conjugated bilirubin, we essentially mean we're past the liver. So in terms of my diagnostic schema, I like to think about it in terms of extrahepatic, such as stones, cancer, autoimmune processes that affect the biliary anatomy, versus intrahepatic processes such as cholestasis brought on by a viral hepatitis.
Yeah, I agree. Are there any specific labs or imaging that you would want to help with your investigation?
Um, can we just repeat that again? Because sometimes there can be lab errors and I don't want to start worrying about something unless I know it's true.
For sure. That's a great idea. Anytime you get a lab result back that's way off from what you were expecting, or could have some pretty decent consequences if you treated the lab.
Hmm.
Always repeat that lab to make sure it wasn't an error. Unfortunately, for this patient, you repeat the lab and it's the same. What other labs would you like to get cooking for this patient?
Okay. Now, I mean, there's a bunch of them on my mind. Maybe we can
Hmm.
go through them one by one of the things I get, and you can give me some
Yeah,
information about them, and then we can talk about the significance. So,
for sure.
thinking about any bleeding, if they're anemic, or if there's any changes in their morphology, I would get a CBC and maybe get a blood smear. So is there anything that's notable from a CBC?
Yeah. So on this patient's CBC, they had normal amount of hemoglobin. They also had a normal number of platelets and white blood cells. When you look at the morphology or what they look like, they had target and Burr cells. So Burr cells are nonspecific, but can be found in hemolytic anemia, liver disease, vitamin E deficiency, or certain drugs. So for this patient, I was thinking maybe something to do with liver disease.
I think that's what we're all worried about right now. So
Hmm.
maybe getting to
Right.
some of those things, a complete metabolic panel. So thinking about looking at some of those liver labs and even like kidney function and electrolytes. Anything notable from that?
Sure. So the AST was elevated mildly at 229, ALT mildly elevated at 157. The
Hmm.
ALK phos was elevated at 2,205, which we can see those elevations in liver injuries, like what we're thinking about for this patient, versus bone remodeling states.
Hmm.
Their direct bilirubin was 13.9. That is high. That's why we're here.
Hmm.
The total bilirubin was also elevated at 17.8. The creatinine was normal and the albumin was borderline low. So, Chris, I have a question for you that I got as an intern.
Hmm.
When you are asking for liver function tests or liver function studies,
Hmm.
what lab results or lab values are you thinking about?
So classically, people think about AST, ALT, which
Mhm.
are, enzymes that are markers of liver injury, but they're not really good at telling you about liver function. When I think about liver function, I think about what the liver's actually producing, which is proteins. So that tends to be
Mhm.
things like albumin, factors, such as things in the coagulation cascade or pathway. So, you telling me that the albumin was borderline low, I would also then want to follow it up by getting maybe a PTINR and seeing how their coagulation is looking. And if it's prolonged, I might be actually worried that they're not producing enough of the proteins to clot properly.
Yeah, you nailed it. I think the hepatologist will be very happy with that answer, and you'll save a lot of folks some grief later on. So, yes, jumping into the PT, it was prolonged at 18.2, with the normal range being 9.3 to 12 seconds.
Okay. I would probably also get a hepatitis panel in this patient, knowing, mom had hepatitis C and is at higher risk of potential like horizontal transfer.
Yeah, excellent idea. The hepatitis panel for this patient was negative.
Okay. Emily, the other thing I might get is a lipase, thinking
Hmm.
about other things that can cause an increase in the direct bilirubin. So, like a stone or something that is backing up in the biliary system that could cause pancreatic damage.
Yeah, that's a fantastic idea. The lipase for this patient was normal, fortunately for the patient.
Okay.
Another lab that we got was GGTP, which is an enzyme that's found mostly in the liver. And so when the liver is damaged, this will leak into the bloodstream. In our patient, it was elevated. I kind of link this to ALK phos or think about them similarly in my brain.
Hmm.
However, ALK phos, like I mentioned, is commonly involved with bone remodeling states. And so I think of GGTP as a little bit more specific to the liver. For this patient, we also got a urinalysis that showed bilirubin in the urine. So, Chris, that was a lot of labs that we just went through. Any imaging studies that you would want for this patient? I 100% recognize that in real life, we were ordering the labs and the imaging studies at the same time. But I'd love to hear your thoughts about imaging studies for this patient.
Yeah. So I think I would typically start with an ultrasound. What do you think about that?
Yeah, I think that sounds like a fantastic idea. But why wouldn't you grab an X ray or a CT for this patient?
So With ultrasound, I picked that because we're trying to look at soft tissues, and ultrasound is great at doing that. X-rays are really not good at looking at soft tissues. It's better at looking at bones and air. So we're not looking for those things, so I don't think it'd be very helpful. CT is good at looking at soft tissues, but it does cause a lot of radiation exposure, and it's quite expensive. So in terms of thinking about an inexpensive and effective modality for imaging, ultrasound is likely our best first choice.
Yep, and that's exactly what we did down in the emergency room. So for our patient, the abdominal ultrasound showed hypoplastic or decompressed common bile duct versus complete agenesis of the common bile duct. Also showed some ascites, mild splenomegaly for age, and slightly enlarged kidneys. Thoughts on that?
Yeah, I think we had been suspecting something like this all along, but this does sound like biliary atresia. So now that we sort of know what's going on, do you mind just explaining to our listeners a little bit more about biliary atresia and the diagnosis itself?
Yeah, sure thing. So biliary atresia is a result of damage to the bile ducts of unknown etiology. So this damage leads to bile being backed up in the liver. Bilirubin can't be excreted and broken down properly, which results in jaundice, eventually leading to cirrhosis and can eventually lead to death. It's even the number one reason for pediatric liver transplant. Typically, patients will start showing signs of jaundice and acholic stools around 3 to 6 weeks of age. And a treatment for it is a procedure called the Kasai procedure, where they attach the small bowel directly to the liver to allow for bile to drain. It's most successful if done before 30 to 45 days of life. And it was really unfortunate that this baby presented after this time period. So she was 6 months of age. It was a big downside of the COVID pandemic, or when families don't have access to healthcare, is that you can miss out on physical exam or any other concerning findings that could have potentially changed the outcome of this baby's course.
I think that's a really good point in thinking about the utility of our well child appointments and those check-ins that we have in the first year of life in particular. Is there any specific medications or medical management that I should be aware of for these children? I know that you talked about, the Kasai procedure as the predominant treatment, but anything else we should consider?
Yeah, and I actually took care of this patient in multiple phases of the hospital. So I took care of them in the ED on nights, and then when I was on the GI service. So when I was on the medical GI team, from a nutritional standpoint, weight may not be the most reliable indicator of nutritional status in these patients due to their ascites. And so you should consider using a mid-upper arm circumference as a better marker of their true nutritional state. They may need a high-calorie formula designed for babies with fat malabsorption, and a reminder that the fat-soluble vitamins are vitamins A, D, E, and K. Speaking of vitamin D, these babies are at risk for rickets or fractures, and so we need to make sure that they are getting their vitamin D supplements as well. From a fluid standpoint, they're at risk of being fluid overloaded with their ascites, and so oftentimes require diuretics and paracenteses. From an infectious disease standpoint, after liver transplant, they are immunosuppressed and require antibiotic prophylaxis. And finally, well child checks are extremely important for all children, especially children in the first year of life. And we need to make sure that children are getting routine physical exams, their developmental milestones are being monitored, they're getting routine immunizations, and that the physician can answer any caregiver questions.
Perfect. I think that's a really nice summary of the outpatient management for this patient as well. So in terms of takeaways from this episode, I hope you understand where bilirubin comes from and the pathway of conjugation through the liver in order to make it a water-soluble compound to be then excreted in the urine or stool. In terms of physiologic jaundice, unconjugated or indirect hyperbilirubinemia can be transiently seen in the neonatal period. However, levels must be monitored carefully, and we must consider treatment with phototherapy to help remove bilirubin that could be harmful. From a physical exam standpoint, yellowing of the skin may not be a reliable indicator of jaundice in children with darker skin tones, so make sure you do a careful eyes and mucous membrane evaluation in these patients. A big takeaway that I want you to know is that an isolated, direct, or conjugated hyperbilirubinemia is never normal and requires more investigation. I hope you appreciate how acholic or light-colored stool is also not normal and how to counsel families about this. For example, it might be worth mentioning to families that acholic stools will not be bright white, but might be more pasty or pale colored, which is something to let their PCP know about. I also want to acknowledge the importance of routine well-child examinations and appropriate healthcare access, especially in this case, how it may have gone differently had the patient been seen earlier in her course. I want to thank Emily for being our content champion for this episode and for Dr. Jody Ehrman for fact-checking. Thanks so much for joining us on First Pediatrics, and we look forward to seeing you next time.